guys, it's Livia. Welcome back to our endocrinology chapter. In the last video, we discussed diabetes type 1 and type 2. We also mentioned some of the complications that can arise from having diabetes. In this video, we'll dive more into the complications as well as the mechanisms that actually cause these complications, which are really high yield for step 1. And before we dive into discussing all of these complications, I also want to point out that the best way to prevent these complications in our patients with diabetes is actually just tight glucose control. So tight glucose control is usually defined as keeping an A1C below 7. We like to see our blood glucoses usually in the 70 to 130 range. These guidelines have gotten tighter and tighter, so I don't think they would test you exactly on the range of blood glucoses, but definitely know that keeping an A1C below 7 is a good target to shoot for when we're talking about tight glucose control and preventing these complications. And additionally, it's important to remember that although tight glucose control does prevent a lot of the complications of diabetes, it has not been shown to have as large of a mortality benefit. So it's important to make this distinction that tight glucose control is more of a morbidity benefit instead of a mortality benefit. Now, diving into some of the complications that can arise with diabetes, I think the first pathway that's important is non-enzymatic glycation. And what is non-enzymatic glycation? Well, non-enzymatic glycation just means that because you have so many glucose particles floating around in your blood, those glucose particles are just going to randomly attach to different proteins through a process that does not require enzymes. So we've talked about in previous biochemistry videos how adding a glucose molecule or a carbohydrate moiety to a protein can change where that protein is allowed to go in the cell, can change the function of that protein, and that process usually occurs intentionally through enzymes. However, in non-enzymatic glycation, you're just having all of these random glucose molecules floating around in your serum because of the hyperglycemia, and they are going to attach to proteins without the intentionality of these enzymes. And this attachment of glucose to proteins is going to create what's called advanced glycation end products, so the end products of adding the glucose molecule to these proteins, which will trap proteins covalently in the extravascular matrix. That is what is going to lead to our small vessel disease. So we're going to have accumulation of these advanced glycation end products. They're all building up in this extravascular matrix, and this is going to lead to thickening of the basement membrane. And thickening of the basement membrane in this extravascular matrix will lead to things like capillary closure in the retina as well as the glomerulus, which will lead to things like diabetic retinopathy as well as nephropathy, which we'll talk about in a second, as well as arterial narrowing in the coronary, cerebral, and peripheral circulation. So what are some of the specific complications that can arise from all of these carbohydrate moieties, these glucose molecules just sticking on to these proteins and trapping them in the extravascular matrix, causing this closure or narrowing of blood vessels? Well, the first complication is diabetic retinopathy. And diabetic retinopathy is going to be characterized by hemorrhage, exudates, microaneurysms, and vessel proliferation in the eye, which will eventually lead to blindness. Diabetic retinopathy is the most common cause of blindness in working adults in the USA. I put working adults here because cataracts is actually the most common cause of blindness in the US, but in young people and people who are still working age, diabetic retinopathy is going to be the most common cause of preventable blindness. And if you look over here on this image, you can see what a fundoscopy exam on someone with diabetic retinopathy might look like, and it is definitely fair game for them to just throw this image up on a slide and ask you what is this disease process on step 1. Zooming into this image over here, something that I'd like to point out, you can see these white spots here. These are often called cotton wool spots and are very characteristic of diabetic retinopathy. Additionally, you can see this little infarct here, also characteristic of diabetic retinopathy. So this is going to be a pretty distinct presentation for diabetic retinopathy, and you should be aware of this fundoscopic exam. The next complication associated with these advanced glycation end products is glaucoma. And glaucoma is caused by vessel proliferation as well as capillary closure inside the eye, leading to increased intraocular pressure. If you remember glaucoma, the definition is increased pressure inside the eye. And certainly when you are closing down these capillaries and you are closing down some of the small vessels, that leads to an increase in pressure, as well as the vessel proliferation can also cause increased pressure inside the eye, leading to glaucoma. And then finally, for our small vessel disease here, you can also have nephropathy. And I think this is really high yield because they love to test nephropathy on step 1. And what's happening in nephropathy is you have these advanced glycation end products binding to receptors and causing hypertrophy, angiogenesis, as well as endothelial dysfunction inside the vasculature that supplies the kidney. Additionally, these advanced glycation end products are causing oxidative stress, they're cross-linking the extracellular matrix, and just leading to overall cellular dysfunction. So it's important to remember that these advanced glycation end products can just cause problems in and of themselves, even when they're not binding to the receptor, causing the specific problems that we talked about above. Overall, the advanced glycation end products are going to lead to thickening of the glomerular basement membrane, glomerular sclerosis, as well as afferent and efferent arteriolar hyalinosis, albuminuria, decreased GFR, and increased creatinine. And basically what I want you to remember here is that the activity of the advanced glycation end products, whether they are binding their receptors or simply wreaking havoc through oxidative stress and cross-linking the extracellular matrix, what they're really doing is they are interfering with the blood supply to the kidney. When you interfere with the blood supply to the kidney, this is what is going to lead to the decreased ability of the kidney to filter blood, which is its primary function, and that's what's going to cause the decreased GFR and the increase in creatinine. And I think that nephropathy here, it's important to remember because it is one of the complications that we are the most afraid of in diabetes. This is what is going to cause people to end up with end-stage renal disease who are diabetics and have to go on dialysis. This is also the reason that we treat hypertension in a lot of our patients with diabetes with ACE inhibitors or ARBs. This is because ACE inhibitors and ARBs are renoprotective and can help prevent the feared complication of diabetic nephropathy, which is resulting from the activity of these advanced glycation end products. And then finally, large vessel disease can also result from non-enzymatic glycation as well. Increased triglycerides, decreased HDL, small dense LDL can lead to atherosclerosis, which can lead to coronary artery disease, which is actually the major cause of death for patients with diabetes. All of these complications that we've talked about up here are more of morbidities. These are going to make it certainly harder to live, but won't necessarily lead to cause of death. Coronary artery disease, however, is still the major cause of death in patients with diabetes, and if they ask you what the most common cause of death for patients with diabetes is, you should say cardiovascular disease. Additionally, I think it's good to remember that when people are at risk for coronary artery disease, they can certainly have peripheral artery disease, which can also lead to limb loss, stroke, things like this. So it's not just the heart, although the heart is still the major cause of death. So we've talked about non-enzymatic glycation, the first mechanism that can cause all of these different complications in diabetes. Now let's talk about another mechanism. This is going to be osmotic damage and the polyol pathway. So what the heck is the polyol pathway? Well, the polyol pathway is a way when you have too much glucose in your system, so the hyperglycemia that we see in diabetes, for some of that glucose to be metabolized into other forms of sugar that can be metabolized in different ways. You don't have to all go through the same pathways that glucose goes through. So what's happening in the polyol pathway, and you can see the pathway down here in this image, is first we have aldose reductase reducing glucose into sorbitol. So we have aldose reductase, which is taking some of our glucose that has built up in too high levels and converting it into sorbitol. After that, we then have sorbitol dehydrogenase, which oxidizes sorbitol and makes it into fructose. So over here you can see sorbitol dehydrogenase oxidizing our sorbitol and making it into fructose. And it's important to remember that this is an oxidation reaction. You can see our OH group here going to a double bonded oxygen over here. So this is an oxidation reaction. And what's important about the fact that this is an oxidative reaction is that oxidizing sorbitol and making it into fructose is what's going to lead to oxidative stress, which is what is going to cause a lot of the downstream complications of this pathway. One of the other mechanisms of complications of this pathway is that the increased sorbitol concentration building up down here is going to lead to osmosis, so sucking more water into some of our cells. And that is another important cause of pathology. One of the pathologies caused by the osmotic damage in the polyol pathway is cataracts. And the oxidative stress, in addition to some of the activity of the advanced glycation end products that we mentioned above, is what is going to lead to lens damage and eventually the formation of cataracts, which can, if left untreated, lead to blindness. In addition to cataracts, the osmotic damage in the polyol pathway can also cause diabetic neuropathy. So because we have an increased sorbitol concentration, this increased sorbitol concentration is going to lead to osmosis. As this osmosis pulls more and more water into specific cells, it can lead to cell swelling and lysis. And cells that are particularly vulnerable to this are cells that myelinate our peripheral nerves. So this can lead to demyelination of our peripheral nerves and lead to the classic type of neuropathy seen in diabetes, which is this glove and stocking neuropathy, meaning that you're going to have neuropathy of your hands and your feet. It will start more peripheral and start working its way upward. And while I did include diabetic neuropathy under the osmotic damage and polyol pathway section, I think it's also important to note that disruption to nervous vascular supply as well as oxidative damage also plays a role. So certainly none of these complications exist in a silo, and there are multiple mechanisms contributing to the symptoms that we see in diabetes. So certainly advanced glycation end products or other pathways could also have a role in contributing to diabetic neuropathy. Finally, in addition to all the complications listed above, it's important to remember that patients with diabetes, especially poorly managed diabetes, are at increased risk for some very specific infections. And one of these infections is mucormycosis or rhizopus. This is when that bread mold is going to crawl in through your nose, creating intranasal infection, can lead to facial swelling, abscesses. The treatment is going to be amphotericin B because this is a mold, this is a fungus. Other important infections to be aware of with diabetes are these diabetic foot wounds. And the cause of diabetic foot wounds is multifactorial. Certainly patients with diabetic neuropathy who can't really feel their feet are at a higher risk for getting a foot wound that they don't realize is there and then not treating it for a while. Additionally, because they have all of these pathways going on that we've talked about, like non-enzymatic glycation, poor vascularization, etc., that is going to lead to delayed wound healing. So it's kind of a spiral effect of you get the wound, you don't know you have the wound, and then you're unable to heal the wound really well. So these wounds just kind of fester over time and can get worse and worse, which is why patients with diabetes are at an increased risk for osteomyelitis. If you have this wound that over time gets down all the way to bone and your bone is exposed, that's a huge risk for bacteria to get in there and cause osteomyelitis, which is why if you ever see a diabetic foot wound where you're able to stick something in there and touch bone, or you even have a high suspicion that bone is exposed, you need to get imaging to evaluate for osteomyelitis because the treatment is not the same as just a soft tissue infection. Additionally, Pseudomonas is a bug that people with diabetes and especially uncontrolled diabetes are at risk for and can be a cause of osteomyelitis. And then finally, candidal infections. Candida loves a sugary environment. So candidal infections of the vagina, of skin folds, of the mouth are more common in patients with diabetes and can even be an early harbinger of a patient who maybe not be diagnosed with diabetes but does have the pathology. I know that was a lot to cover. Let's quickly recap what some of the high points of this video. So there are two mechanisms to be aware of that lead to most of the complications that are associated with diabetes. The first is non-enzymatic glycation, or the attachment of glucose molecules to proteins, which plays a role in diabetic retinopathy, glaucoma, nephropathy, and the major cause of death in patients with diabetes, coronary artery disease. Then there is the polyol pathway, which plays a role in cataract and diabetic neuropathy formation. And finally, it's important to be aware of several of the key infections that are associated with diabetes: mucormycosis or rhizopus, osteomyelitis, diabetic foot wounds, which can definitely be caused by Pseudomonas, and finally, candidal infections. And then how do they ask you about this on a board style question? Well, something they might ask you is a 56-year-old man with a history of poorly controlled type 2 diabetes presents for his annual checkup. His medications include metformin, glipizide, lisinopril, and insulin. Labs reveal a creatinine of 3.5, increase from baseline of 1.0, and a reduced GFR. What is the most likely underlying mechanism for this patient's renal pathology? Okay, so this is a patient with poorly controlled diabetes. Certainly does not have this A1C less than 7, and that is why he's at higher risk for some of these diabetic complications here. They also tell us that he's on metformin, glipizide, which is sulfonylurea, as well as insulin. They also say that our patient is on lisinopril. Lisinopril is an ACE inhibitor and is a great choice to treat hypertension in patients with diabetes because of its nephroprotective effects. However, this patient still has a creatinine of 3.5, which is way above his baseline of 1, and a decreased GFR. So I'm concerned that this patient may be developing some diabetic nephropathy despite our best effort. The question then asks us, what is the most likely underlying mechanism for the patient's renal pathology? And because you watched this video, you know that the mechanism most responsible for diabetic nephropathy is non-enzymatic glycation, and I would look for non-enzymatic glycation or advanced glycation end products in the answer on step 1. So I hope this video was helpful, and I hope you understand a lot more about diabetic complications, and I'll see you next time.